Thank you again for joining us for today's webinar, Mind the Gap, Improving Quality Measurement and Accountable Care Systems. I will now turn it over to our moderator, NPC's Vice President of Health Services Research, Kimberly Westridge, for a few housekeeping items and introductions.
Thank you so much, everyone, for joining us today. Good afternoon or good morning, depending on where you are. I hope it's a little less snowy where you are than it is where I am. Last October, the National Pharmaceutical Council hosted a day-long conference on the topic of quality measurement and accountable care systems, and it was so well received that we wanted to pull out the highlights from the day and share them in a webinar for people who weren't able to be with us last year. So to that end, today I am joined by an incredible panel that needs no introduction, but I'm going to introduce them anyway. First is Dr. Mark McClellan. Dr. McClellan is a Senior Fellow and Director of the Healthcare Innovation and Value Initiative at the Brookings Institution. His work there focuses on promoting quality and value in patient-centered healthcare, and he has what I would call a truly unique background. Dr. McClellan has been trained both as a doctor and an economist, and he served as both former administrator for CMS and former commissioner of the FDA. Following Dr. McClellan is Dr. Tom Valek. Dr. Valek is currently a partner with Discern Health. At Discern, he focuses on transforming the healthcare system on the front lines to achieve better health and healthcare outcomes at lower cost. He has national leadership experience in both quality and performance-based payment from previous positions with the National Quality Forum and CMS. And speaking of CMS, we are also joined by Dr. Kate Goodrich. Dr. Goodrich has been with CMS since 2011. Her current position is Director of the Quality Measurement and Health Assessment Group in the Center for Clinical Standards and Quality. In this role, she currently oversees the implementation of 12 quality measurement and public reporting programs, and I hope that's the right number because it seems like it keeps creeping up and up and up. And in her spare time, Dr. Goodrich also continues to practice clinical medicine as a hospitalist and associate professor of medicine at George Washington University Hospital. So quality measurement isn't actually a new concept. It's been around for a while, and it's been growing in importance over recent years. Arguably, one could say that the timeline began in 1999 when the Institute of Medicine released its seminal To Err is Human report, and the National Quality Forum, NQF, was established. But at that time, quality measurement was still figuratively sitting in the back of the theater. I'm going to walk you through a quick timeline of how quality measurement moved up to the front and center position that it's in today. It moved up a couple of rows in the early 2000s as IOM released another report, Crossing the Quality Chasm. CMS started some demonstrations, the Hospital Quality Incentive Demonstration and the Physician Group Practice Demonstration. We also had the Patient Safety and Quality Improvement Act establishing patient safety organizations. Now, 2007 was a really big year for quality measurement. The Institute for Healthcare Improvement coined the term Triple Aim. NQF convened the National Priorities Partnership, and CMS delivered its Hospital Value-Based Purchasing Plan report to Congress, and they also initiated the Physician Quality Reporting System. Then we had the passage of the Affordable Care Act. In 2011, the publication of the National Quality Strategy, the convening of the Measure Applications Partnership by NQF, and here we are today in 2015. Quality measures are front and center, and they've really become the new normal. It was just 1 month ago today that Secretary Burwell called for half of all Medicare payments being tied to quality or value by 2018. So what does this mean? How do we succeed in this new environment? Moving payments away from fee-for-service and towards quality and value will help address overutilization and waste in the system. Incentives and tools such as quality measures, value-based purchasing, readmission penalties will all help move us towards appropriate use. But it's difficult to stop a pendulum in exactly the right place. Without getting the incentives right, the pendulum may actually swing too far into the realm of underuse, a system where diagnoses or treatments are delayed or suboptimal. So how do we use quality measurement to help us achieve high-value health care? I'm pleased to turn the floor over to Dr. Mark McClellan to address that topic today.
Kim, thank you very much for that introduction, and it's a real pleasure to be on this call with Tom, with Kate, and with all of you. This has been a lot of fun to work on this report because this topic of quality measurement is becoming increasingly important. I'd like to go through a few topics to set up the report that Tom's going to describe, and then Kate will, I'm sure, put this all in a broader policy context in terms of what CMS is doing. But first of all, just a reminder of some of the important reasons for improving quality measurement. I think we're on a trajectory where performance measurement is increasingly important in achieving the goals of a higher value healthcare system. Then I want to illustrate some of the uses of performance measures and this trend in focusing more on high value healthcare delivery through the implementation of the Accountable Care Organization program. ACOs have become much more common over the last few years in both the public and private sectors. And these illustrate not only some of the potential benefits of changing payments in a way that they're better aligned with high-quality care, but some of the challenges in pulling this off and the importance of performance measures. That's going to lead into a discussion of some of the key findings and recommendations from the Minding the Gap report, and I'm going to spend the last few minutes talking about some next steps from here. So next slide highlights some of the many reasons why performance measurement is becoming more important. So we're getting better at it from a technical standpoint with better electronic data and so forth, but it's also becoming a much more central part of many healthcare policies. First and foremost, better measurement of things that matter to patients, not just the volume and intensity of services, is really important for guiding clinical care redesign. So figuring out where the gaps in quality are is a helpful prerequisite for making changes in care delivery that clinicians can undertake, that patients can undertake in order to get to more effective care. Beyond that, there are a lot of policies that can support getting to more effective care as well. I'm going to spend time focusing on payment reforms in the next few minutes, and quality measures are integral to accountable care organizations and other types of alternative payment mechanisms. But I also want to highlight how important it is for the other part of healthcare financing, and that's the benefit side of the insurance benefits that individuals receive have traditionally been very much tied as well to the volume and intensity of services. You have co-payments up to an out-of-pocket limit, but increasingly we're seeing value-based insurance designs and other reforms which also depend on quality measures to implement them effectively. A lot of regulatory reforms in the past have focused on things like structural requirements on providers and the like, but as we get better measures of quality of care and outcomes for patients, that can enable more flexibility in other types of regulatory programs, certification programs, inspections or alternatives to inspections and the like. There have been a number of medical liability reforms that in recent years have focused on demonstrated evidence of high-quality, safe care, creating a presumption against liability. So that's performance measurement and liability reform. And obviously, performance measures are critical to competition working well in healthcare. It's about price and quality, and whether it's on the ACA exchanges that are being implemented now or when we implemented Medicare Part D during my time at CMS, measures related to quality and access to medical services are absolutely critical in helping people make confident decisions about their care and helping to drive these reforms in care delivery. So a lot of reasons why this is important, and on to the next slide, we'd like to talk a little bit more about the ways in which it's important for payment. And heard from Kim about the issues related to overuse, underuse, and misuse, and it is true that fee-for-service provides some much-needed help for some high-value treatments that can be costly. But I just want to emphasize that value in healthcare includes a growing and increasingly diverse range of healthcare and non-healthcare types of innovations. So obviously it's more effective treatments for unmet health needs, new drugs, new devices, new procedures, and the like. But also things like using electronic records effectively or analyzing data effectively to identify which patients would benefit the most from particular treatments, and using technologies that may not be viewed as part of traditional healthcare, but that certainly can make healthcare delivery work more effectively. Wireless monitoring from home, telemedicine, and other personalized health tools that you can use on your own, much more convenient alternatives to going to the doctor or going to the hospital, and can often head off costly complications as well. At the same time, we're also seeing new sites of care delivery, convenient community clinics, provider team approaches to care that involve nurse practitioners or pharmacists or other types of health professionals to help patients with adherence to treatments, to help with continuity of care, to provide less costly alternatives to physician or hospital care. And then finally, a lot of non-medical strategies for health improvement, behavioral changes, changes in diet and lifestyle, which can be supported by an increasing range of innovative healthcare delivery systems. And as the next slide shows, while some of these types of innovations in care tend to increase costs, especially some of the new treatments, especially in the short term, many of these other types of innovations can help reduce costs. And next slide, the challenge with fee-for-service reimbursement is that there's not that much support for many of the types of services I just described. We implemented the forerunner of the Medicare ACO program, the Physician Group Practice Demonstration, back in 2005, not because we were trying to invent a new payment mechanism, but because many providers had come to us and talked about things that they were doing in this list of services in blue, care coordination services, using email, team-based approaches to care, helping patients with adherence. They were improving outcomes and lowering costs, but that weren't getting reimbursed at all under fee-for-service, and that tended to reduce fee-for-service reimbursement because they headed off hospitalizations and even the need for doctor visits, and were more convenient for patients. So next slide, the real motivation I see for moving to new payment methods that are more tied to quality and therefore more reliant on quality measures is the need for supporting this much more personalized, preventive, individualized approach to care, where lots of the technologies and analytic capabilities and so forth that I just mentioned don't make sense for every patient, but targeted and combined in the right way for each individual can potentially get to much better results. It does require more flexibility in how care is delivered, and in order to do that while keeping costs down, there's a need for accountability around cost and quality of care. So accountable care payments, I think you can view as really being a shift from kind of a fee-for-service track of payment to putting more weight on payments at the episode or case level, or payments at the person level, that are really intended to allow more flexibility for healthcare providers to do what patients need the most to get to the best outcomes and lowest costs. And next slide, ACOs, which do this by setting up a second payment track that's tied to better performance in terms of quality outcomes at the population level and lower cost performance, or an example of that. They've been growing rapidly in both the Medicare and non-Medicare context. Onto the next slide, we're up to over 600 ACOs today, which include over 400 Medicare ACOs that are delivering care to close to 8 million attributed beneficiaries, more beneficiaries in commercial ACOs, and a growing number of states implementing Medicaid ACOs that include not only combining funding streams at the person level from traditional healthcare programs, but also are increasingly integrating social services, community-based services as well, since, again, these non-medical factors influencing health outcomes may be more important, more effective than some medical intervention. There are some early results from these programs. What I would want to highlight here is that the Medicare ACOs seem to be doing quite well in terms of the measures of quality that they're accountable for, and I'll talk more about those measures in just a minute. There have been some savings that CMS has reported from the first year of the program. and those savings have been concentrated in a subset of ACOs that are taking some concrete steps to reform the way that they're delivering care with an eye towards saving money at the same time as they're improving outcomes and results on the ACO performance measures. For the commercial ACOs, there are not such systematic results together, but again, from the perhaps selective results that have been published or reported, it looks like there are similarly significant improvements in measures of quality and also some significant savings and a reflection of the support in the private sector for these efforts. All of the major commercial plans are engaging in expanding their ACO activities, and a growing number of states are undertaking these efforts in Medicaid as well. So next slide. I wanted to talk a little bit further about the quality measures, just kind of highlighting some of the opportunities and challenges here. This is a list of all of the Medicare ACO performance measures. They fall into a number of categories, including patient and caregiver experience. These are the so-called CAP survey measures, measures that relate to care coordination and patient safety. Many of these measures come from claims data in terms of readmissions occurring that perhaps shouldn't, or admissions occurring in areas that are sensitive to ambulatory care. So more effective ambulatory care could prevent some of these admissions in the first place. A number of measures related to preventive care, again, many captured from claims data on the use of preventive services that are recommended for broad populations of Medicare beneficiaries. And then some measures related to particular common conditions among Medicare beneficiaries, including diabetes, high blood pressure. And you can see the measures here include some clinical information, short-term proxies for long-term outcomes, like hemoglobin A1C level being a good indicator of how well controlled a patient's blood sugar is, and blood pressure control obviously being important, cholesterol control as well. And similarly, for patients at risk for coronary artery disease, lipid profiles, and also some process of care measures like use of aspirin. So on to the next slide. So that's a list of 33 measures, which many ACOs regard as being too large of a number of measures, but important for demonstrating that the steps that ACOs are taking to improve, to reduce costs and change care are also leading to improvements in outcomes. There are a lot of systems being developed today to support these improvements in care, including clinical data registries, regional health information systems, analytic systems that can be developed in-house or being provided by third parties to ACOs and to other healthcare providers who are participating in payment reforms like ACOs. But there are some challenges here. So some progress towards supporting better care and measurable improvements in care, but some challenges as well. On the next slide, this attempts to highlight some of the current challenges to quality improvement, which again is the core goal here, and measurement to support it, which is about, again, getting the payments and the other healthcare policies to align with the goal of quality improvement. And it starts with problems of measurement. So these different policies, including payment policies like ACOs, often have different measures that they use for supporting better quality of care. The development of these measures is limited by difficulties in getting the needed information out of existing systems for delivering care. So most of the measures that I just talked about are derived either from claims information, which providers may not have right when they're making decisions for patients. They have to be produced and reviewed after the fact, or they come from clinical data that healthcare providers can produce, but often through additional steps, like reviewing their medical records and then producing as a separate step reporting on the quality measures. Now this is changing, but it has been a barrier to getting timely information available to clinicians when they're making decisions, and then having that same information be the basis for performance measurement, hopefully in an aligned way. And as a result, the support for actually improving quality and for moving forward on these significant payment reforms that, if done well, can target resources in a much more individualized way to patients who need them, is slower progress on that front. So next slide highlights some of the challenges for relying more on quality measures as a way of driving payments and our other healthcare policies to support quality improvement. And first of these, and the main focus of the report, is on the availability of valid and consistent measures that are meaningful, that capture what matters for particular types of patients, measures that are actionable, that can be collected and used in a way that actually leads to improvements in care. So on to the next slide. This is a summary. Tom is going to go into more detail on the report, but this is a summary of the 20 conditions that were covered in the report for assessing just what is going on in terms of performance measurements in each of these areas. These are, as you can see, diabetes, ischemic heart disease, chronic kidney disease, and so on down the line, are conditions that collectively account for a large part of the healthcare burden facing the U.S. population in general and the Medicare population in particular. What the report did, and again Tom will describe in more detail, is examine the availability in the Medicare Shared Savings Program, that's the Medicare ACO program, of measures that related to these conditions either directly or indirectly. Direct measures would be measures like hemoglobin A1C control for diabetes, so a condition-specific measure, in that case oriented towards outcomes for that particular condition. Measures that are not so directly related would include things like those patient experience measures that I described before, potentially broadly applicable screening measures, which might be part of care, albeit not the most important part of care for some of these specific disease populations. So that gets into the indirect category. In this, as you can see from the results, for some conditions like ischemic heart disease and diabetes, there was pretty extensive representation in the Medicare Shared Savings Program measure sets, and measures like patient experience and some of the screening measures apply broadly across populations. But we did note as well that there's some additional outcome measures available that could fill these gaps, whereas in other areas there just aren't good measures available. So, for example, for HIV or hepatitis C, there have been some outcome-oriented measures developed, like viral load measures. In other conditions, like many cancers, there have not been measures developed that are clearly relevant and capture important outcomes for those conditions. So I'm going to go through the next two slides quickly, since I think I've mainly covered them. So this is just a list, again, of those 20 conditions. And the next slide highlights the conditions that have different types of measures available, including the screening and prevention measures, which are, again, potentially relevant to a broad range of conditions, and particularly relate to prevention of influenza, the flu vaccine measure, and mammograms for breast cancer. Then some conditions where there are clinical outcome measures, diabetes, hypertension, ischemic heart disease, and major depression. Some utilization-based outcome measures related to preventable hospitalizations, as I mentioned earlier. Those so-called ambulatory sensitive conditions include asthma and COPD, but not specific measures, rather only the so-called indirect measures that might be relevant to these other important conditions. So the report goes on to describe some of the ways to address these measurement gaps, and that's in the next slide, where there may be outcome measures available or in development, but then where there may be appropriateness measures related to potential overuse or underuse of services, cost of care measures, composite measures. In all of these areas, we found significant gaps, and again, Tom will talk more specifically about the details. I did want to particularly highlight on the next slide cross-cutting measures as a means for addressing gaps across a number of conditions while still maintaining a concise number of measures. Again, there is an issue of reporting burden for providers who are very interested in measures that are meaningful, but that do not create a large amount of burden, and I'll come back to that as well. These cross-cutting measures that could be relevant to specific conditions, but potentially can be collected for a broader range of conditions include measures of patient experience with care, of which there are some already in the CAHPS measures in the Medicare ACO program, measures of patient engagement. So there are validated measures of patient activation and their engagement in their care, which would be relevant to a large number of these conditions for whether patients feel like that they are actively engaged in getting the kind of care that they want. Measures of health-related behaviors could be relevant to a set of chronic diseases, such as those associated with diabetes, obesity, and the like. Measures related to patient functional status and health status, which could come from patients themselves. Those have not been used widely yet for particular conditions, but the functional status measures could cut across multiple conditions. Measures of care coordination and other utilization-related measures. Again, these can potentially enable more coverage for a broader range of conditions without significantly increasing the number of measures. And next slide. On recommendations for closing these gaps, the report highlighted 5 intended to provide a more comprehensive framework for accountable care measure set developers to assess where there are gaps and to perhaps prioritize where to fill them in. The report highlights, and kind of recognizing the cost of data collection and reporting for quality measures, the report highlights the importance of and the opportunities to focus on some early indicators or signals of potential quality gaps. For example, measures based on utilization that show preventable hospitalizations or other concerning patterns of utilization, indicating the potential value of developing more extensive measures to help identify the source of those quality gaps and whether these early indicators or signals really identify quality problems. Also, areas where we know from other clinical research that there are significant variations in quality and the ability to reliably measure quality in each of these areas may differ. Again, just because something isn't measured well doesn't mean there's a big problem there, especially if, as is the case with many of the payment reforms that have been implemented so far, while they've shifted away or started to shift away from fee-for-service, they're still largely fee-for-service-based systems, like most of the Medicare shared savings ACOs. So these are areas for priority work and evolutionary work as payment reform and quality reporting systems can advance. Tom is going to talk as well about a layered approach with an emphasis on providing more data internally and more effective support for quality improvement internally to healthcare organizations, with a subset of that information moving on to public reporting of measures that matter to consumers and for payment for measures that do have more of an impact on overall outcomes. So again, it doesn't necessarily need to be a very large number of measures and a very large increase in reporting burden and quality measurement burden to make progress on addressing these gaps. Next slide. The report concluded that significant gaps do exist in current accountable care measure sets, that these gaps can be addressed through that approach to prioritization and identifying where the likely most critical gaps are with the best opportunities for filling them. And the report described how better measures and new approaches to measurement, including cross-cutting measures and this layered approach idea, could be used to make feasible progress in addressing the most important measurement gaps. The report emphasized, as have many others, that outcome measures, cross-cutting measures, patient-reported measures, measures that mean the most to patients are probably most important for quality reporting and payment system. And again, if done judiciously, this does not mean a lot more measures. It means more effective evolution in the measures that are reported and that are a basis for payment reforms like ACOs. Next slide. We just want to highlight that while getting better, more valid and consistent measures is important, there are other steps too on the journey to really achieving quality improvement and much higher value health care through the use of measures. So in developing these measures, it's important to consider reporting feasibility and burden. Kate, I'm sure, is going to talk about the steps that CMS is taking to move away from measures that require providers to take additional steps after they deliver care to administratively report on measures, and steps away from relying on data that providers don't have at the time that they're making clinical care decisions and therefore can't use for quality improvement. Those kind of after-the-fact steps are both more burdensome and less supportive of actual improvements in care, and need to be, we need to continue to make progress on addressing that kind of reporting feasibility and burden issues as we make further progress on supporting quality improvement. Further, just because something can be measured doesn't mean it can be measured reliably, especially as measures get drilled down to the level of from broad populations, say for an ACO, to particular provider groups or even particular providers. Population size issues or may affect the reliability of the measure. Also, population risk may differ, so risk adjustment and other techniques to address noise and bias in the performance measures are areas where more progress is needed. And all of this should enable more support and more incentives for use. I like to think of this as hopefully a virtuous cycle where we've taken some initial steps with, say, shared savings on top of fee-for-service payments to move towards accountable care type payment arrangements. As we have better quality measures and especially better quality improvement system support that can produce those measures, it should be feasible for making larger movements away from fee-for-service payments, giving providers more flexibility and more of an ability to put the resources where patients most need them, into telemedicine, into home-based care, into new approaches to delivering care that can improve outcomes and save money, but that weren't supported very well under fee-for-service, while still making sure that patients that have the highest cost needs and really do need the more intensive treatment can get them. Indeed, as we're heading towards more personalized treatments for cancer, for many other conditions that are both highly effective but also very costly, having this ability to target those treatments to the right patients much more effectively, I think, is absolutely essential to getting to a high-value, sustainable healthcare system, one that provides access to innovative, valuable treatments, but does so as affordably as possible. And the next step, just to close out, a couple of points about supporting, on the next slide, supporting more effective use of performance measures. I think as CMS has done recently and many in the private sector have done, there's been a very clear statements that we are moving down this road towards relying more on performance-based payment and data systems to support them. In addition, CMS has taken some steps. There's a lot of discussion in the proposed revisions in the ACO program and many of CMS's other payment reforms that are underway to provide more timely data from Medicare that can be used in supporting care improvements so that providers know where those gaps in care are, know which patients are showing up at the emergency room and so forth, and have the most opportunity, therefore, to improve their care. Private payers are doing this as well. Interoperability, practical steps towards interoperability can help with this too, and it's been a main goal of the recent ONC report on progress towards an interoperable health IT system. Some practical steps there would include focusing on key data elements that are needed for improving outcomes in these particular clinical areas. Less burdensome ways of developing performance measures from systems used to support care rather than measures that are administrative burdens for providers to collect and report in addition to all that they have to do to deliver care. Progress is happening there as well. But this is all challenging, and some of the most effective and successful reforms, especially in the private sector, around accountable care, have given providers some upfront help and technical support in implementing better quality measurement systems in their own practice, better analytic systems, which then can be used to produce these performance measures as well. The result of all that, hopefully, is what's in the next slide, and that is a much smoother and more effective process for supporting quality improvement through better performance measures, with more aligned and meaningful performance measures. As the report outlines how we can get to that come from data that are actually collected and used in care delivery, so that there is no additional data collection, as shown in the middle of this slide, no or minimal additional data collection required to actually construct performance measures from these systems that are used to support care. That can lead to lower cost, more effective use of performance measures in payment systems and in other policies like certification, some of those regulatory policies that I described before, that can all in turn make providers much more confident about taking steps into new approaches to care delivery that they can be more sure will improve patient outcomes and lower costs at the same time, and make it easier to support high-value innovations in care, whether those are expensive innovations or cost-savings innovations. It's really all about value. So that's what we're aiming for. This report is an important step on the way to getting there, and I'd like to turn now to Tom to present the report in more detail.
Thank you, Mark, and it's a pleasure to be on the webinar today with Mark and Kate. Mark was the co-chair, along with Jerry Pinso from the Medical Group Association, of the project and a roundtable that we had to inform the recommendations and conclusions that Mark has shared with you. And Kate's team was also engaged as part of that roundtable. And so we really appreciate NPC sponsorship of this work. And in the next slide, this is my placeholder to remind everyone that the report that Kimberly and Mark have referred to is posted online. You can find it on the NPC's website or on Discern's website, and you can get all of the details behind the findings, conclusions, and recommendations that we're all addressing here today. The next slide is the highlights, the key takeaways from the report, that we did find gaps in accountable care measure sets, and that those gaps can't be adequately addressed with more of the same types of measures and measurement strategies that we've been using. First of all, that would be impractical in terms of the number of measures. Mark talked about measurement burden, and I'm sure Kate will as well. And also, there would be missed opportunities for better approaches to measurement, and so we wouldn't want to miss out on that just by adding more and more of the same measures. So we're looking for strategies to efficiently fill those gaps with preferred types of measures that Mark reviewed, and also new approaches, which is in large part what I'm going to be focusing on when I talk about the solutions that were proposed in the report. The next slide just reviews the background for the project that Kimberly set up nicely, and also came through in Mark's comments. We have quality measurement as a tool tied to financial incentives as one of the many approaches. Mark reviewed many others beyond measurement that accountable care systems are using to promote improvement. And the incentives are geared toward controlling costs, with the focus of the measure sets being on relatively few clinical conditions, particularly in terms of direct measurement where the condition occurs in the measure denominator. So given that measurement does influence priorities in care delivery, we need to think about the impacts of that to at least monitor the effects that measurement is having in these accountable care systems, and to think about how to make the sets broader, deeper and to use new approaches that don't necessarily require more measures in order to understand the impacts of measurement. So the next slide then outlines the project purpose that's responsive to that background. We wanted to examine the gaps in current accountable care measure sets. Both MSSP and the NCQA ACO set were used. There are also commercial sets out there for which you could do a similar analysis. We identified priority measure gaps for the conditions that we reviewed, and then understanding the implications of those gaps helped us to inform recommendations and solutions to policymakers. The next slide then just outlines the limitations of the project. We've stated what we wanted to accomplish through the work, but we also want to note that measurement is only one of the tools, and we're focused on measurement here, but there are many other things that accountable care organizations and programs that policymakers are putting in place are doing beyond measurement in order to get to improved care. We have to also be careful that we have reasonable expectations about what measures and measurement can accomplish and not overdrive the headlights, so to speak, of measurement. Want to make sure that we emphasize that lack of measurement does not necessarily imply that providers are not delivering high-quality care in areas that aren't specifically being measured. So professionalism drives professionals and institutions to focus on better and better care over time, and measurement helps them achieve that. Our focus in this project was not just on ACOs. We've talked about ACOs and shared savings approach, but these principles that we're going to be talking about could be applied to bundled payment, for example, or other kinds of performance-based payment approaches. To remind the audience that inappropriate care is not just about underuse, where we might see that from financial incentives, but it's also about overuse, and that the project scope really is focused in on policy-level solutions. We aren't recommending a specific measure set or specific changes to the measure sets at this point in time, but that could be a next step that we could build on in terms of the current project. And then that our solutions and recommendations are not meant to suggest that you need measures, particularly process measures, for every condition that a patient might have within an accountable care population. That's just not feasible, which is why we've come up with these other solutions. So as Mark mentioned, the project focused on 20 conditions. The next slide lays out the selection criteria that we used. Things that you would expect, like prevalence, like conditions that have high cost drivers, like specialty pharmaceutical use, imaging, surgical procedures, hospitalization. But we also wanted a mix of conditions from other perspectives in order to have a broad review of what's in and not in accountable care measure sets. So in the next slide, you see that mix, a mix of conditions that apply to different ages, different genders. You see chronic and acute conditions. We have behavioral mental health represented, medical and surgical conditions, and also conditions that require a mix of traditional and specialty pharmaceutical treatment. The next slide is the logic model that we walked through for all 20 conditions in order to develop our conclusions and recommendations. So first we looked at the guidelines for each of the conditions to determine those important endpoints that are diagnostic and treatment goals. And then we looked at the current measure sets. MSSP, the Medicare Shared Savings Program, was kind of our focus, but we also looked at the NCQA ACO measure set to identify gaps relative to the guidelines. So once we identified gaps, then we looked at the available measures that might fill those gaps, and where we didn't find available measures, we identified those as measure development opportunities. And across all those steps, that helped inform the conclusions for the project. So to get to our findings, the next slide is what we found for the Medicare Shared Savings Program measure set for ACOs. This is a bit of an update of the slide that Mark presented, which was the slide from our report last fall. This is updated based on the most recent physician fee schedule final rule, which had some updates to the MSSP measure set in it. So you'll see here that that there are 10 conditions that have direct measures. So there are 13 measures that apply to 10 of the conditions that we reviewed. So some of the measures applied across multiple of these conditions. But basically half of the conditions we reviewed had measures with the condition in the denominator. But then there were also a number of cross-cutting measures, like measures of patient experience and care coordination, that applied more broadly across the condition. What you don't see on here are a couple of other facts I'll give you, that almost half, actually a little bit over half of these measures in the ACO set are outcome measures. So about 18 of the 33 measures in the set are outcome measures, a number of those being the CAHPS, patient experience of care measures. And 13 of the 33 MSSP measures, as I mentioned, apply directly to the 10 conditions, in addition to the cross-cutting measures that you see here in the lighter color. In the next slide, you see the analysis for the NCQA ACO measure set. So in this set, 23 of the measures that NCQA uses for ACOs apply directly to 12 of the conditions. So a few more conditions represented, including ADHD and chronic low back pain, which you might think would be more applicable outside the Medicare population. And in terms of outcome measures, there are 13 of the 40 measures in the NCQA ACO set are outcome measures. They don't have the CAHPS measures in that set. That's a concomitant measure set. But they do have some measures of resource use that are outcome measures for the NCQA set. So once we determined where we had measures available and measures to meet gaps, we did an analysis of the available measures in the next slide that we might use for conditions that don't have direct or indirect measures as the need may be in those accountable care measure sets. And we did find that even though there are many more process measures available that we wouldn't necessarily see as great candidates to bring into the ACO measure sets, even if they do directly apply to specific conditions, we did find some outcome measures. And in fact, some of the outcome measures that we found in our analysis ultimately were ones that CMS added, particularly around depression, one that comes to mind, to the MSSP ACO measure set in the last round of rulemaking. So the next slide identifies the priority measure types that our roundtable found, and Mark reviewed this slide, so I don't need to go into depth here, but you'll see that the priority measure types included outcome measures, cross-cutting measures that efficiently assess performance across multiple conditions, measures of patient-centeredness, appropriateness, cost of care, and composite measures. So these were the preferred measure types that were identified. And we give some specific examples here, and there's more discussion about these in the report that you could find online. The next slide, Mark also reviewed, which were the primary recommendations from our work, the importance of prioritizing, given that we really want to focus our measurement resources on opportunities to improve care, and where we've seen that the utilization data, for example, could point us in a direction where there might be a problem. The second step in the recommendations is where I'm going to focus the rest of my comments before we turn the presentation over to Kate. The third step is around those measure types that we saw on the last slide, and preferentially using those and moving away from condition-specific process measures for external accountability. The fourth recommendation has to do with addressing barriers to measurement, and Mark closed with some of those and some solutions there. And then the last is about continuously improving. It is important to have feedback about the impact of measurement. We need to know when to retire measures, when we need to add measures in certain areas, and what impact we're having overall to make sure that the benefit of measurement is exceeding the costs. So as I said, I'm going to be focusing in, starting with this slide, on the solutions that we identified for alternative measurement approaches. And it uses a schema that I'm going to be setting up here. So imagine yourself as a policymaker developing a measure set for a program, whether it would be an ACO program or perhaps even a bundled payment program. And you would want to look first at your population and see what kinds of conditions you're wanting to address within that population. So the columns here represent the conditions for a certain accountable care population: diabetes, rheumatoid arthritis, multiple sclerosis. There could be many others. And then we have measures that apply to those conditions. Some of the measures apply directly, and those are the boxes in the columns under the specific condition. Some measures could apply across or indirectly to multiple conditions, and those are the cross-cutting measures you see with the green arrow. And you see that we have gaps. In some cases, we have gaps where we already have measures, like for diabetes. That doesn't mean that we don't have gaps that have to do with the depth of coverage. So, for example, there may be certain complications of diabetes where we don't have measures yet. Or there may be breadth of coverage where some conditions aren't covered at all, like, for example, multiple sclerosis. So in the next slide, one of the options that we have would be to develop new measures to fill gaps. Perhaps we want a good outcome measure for rheumatoid arthritis, and so we want to bring in a functional status improvement measure into that measure set. And in fact, the rheumatologists have brought a measure through NQF endorsement that might be useful for assessing functional status of rheumatoid arthritis patients in accountable care measure sets. And in addition to adding condition-specific measures to fill gaps, in the next slide, we can add additional cross-cutting measures to multiply the efficiency of the measure set, perhaps getting to access to specialists, which might be a problem that we have for rheumatoid arthritis or multiple sclerosis. Then in the next slide, we consider bringing in existing cross-cutting measures in addition to measure development. So we might have a measure out there that addresses a gap, like for medication adherence, for example. So let me move into two alternative approaches that don't require adding more measures to a measure set. So the first is the layered measurement approach, and the next slide is the diagram for that. So the layered approach reflects that accountable care systems use measures at multiple levels. Next slide, please. There we go. At multiple levels, at what we see here as the highest level in the diagram for external accountability, at the population level. At the middle row is for internal management of performance at the system level. And then we have a row for internal improvement measures at the provider level. So the key is, in the layered approach, to ensure that the measures across these different layers within the layered approach map to one another, so that you can use measures in a more focused and targeted way. so that we can make sure that our measurement efforts are actually having maximal benefit for the cost. And you would want to use different measures that fit the different purposes of these layers. So for example, for external accountability, outcome measures, including patient-reported measures, and cross-cutting measures may be best suited for external accountability because they allow for efficient reporting of the information that's most meaningful to program implementers and patients. So you see here outcomes like diabetes complications rates, depression remission, or patient-reported care coordination and communication. And then mapping to that, at the internal management layer, you can see composite measures might be particularly useful for internal management to indicate that appropriate diabetes care is being provided. And you see that the cross-cutting measures of care coordination and communication can flow down as the cross-cutting measure can flow down to internal improvement to inform actions that providers can take. But you might want to include process measures at the internal improvement layer in order to give the providers very actionable steps that they can take for improvement. So you see how the measures work together here, and some are more appropriate than other measure types at these various levels. But the providers would have the flexibility to determine which measures they wanted to use for internal management and for internal improvement to map up to the external accountability measures to help them be successful in their performance reporting. And the next slide just has a second example of this for rheumatoid arthritis care, and you can see this example also in the report online. So the next slide then takes us into the modular approach to measurement. And this is the setup for the modular approach. This strategy allows, again, more targeted and flexible use of measures to address gaps. It basically calls for a more granular measure set underneath the general ACO population measure set for some condition that is deserving of focus for whatever reason. Perhaps the provider and the payer want to focus on improving quality or cost for that subpopulation, and want a more granular set of measures for monitoring improvement. Perhaps monitoring indicators have shown within that system that there's a problem there, and maybe a commercial payer wants to partner with that system to improve their care, so they can carve out the population for a more specific application of accountability measures and incentives. As an example, on the next slide, specific for oncology patients, you can see types of measures that you might want to include, whether it be for general oncology care or condition-specific care, underneath the general ACO population set. So while the broader set, including cross-cutting measures, would still apply to the oncology population, additional measures would also apply, like oncology-specific outcomes, survival, complications, processes of care, palliative care, for example, with the cross-cutting measures translating from the general ACO set into the condition-specific set. So my last slide here, conclusions. Accountable care, as we've all discussed, depends on having these meaningful measures and more efficient approaches to measurement that I've presented here. And to achieve success in these new models of delivery and financing, we need to identify the priorities for improvement and then apply the preferred types of measures as well as new approaches that allow us to be innovative in measurement. And those layered and modular approaches are examples of innovations that could be adopted for accountable care. So at this point, I'd like to turn the program over to Kate Goodrich, who's going to talk from CMS perspective.
All right, thank you, Tom. Hi, everybody. Very good to be with you today and to be involved in this work. So if we could just move to the next slide. This slide sort of depicts where we are now in our current state and what we would like to see in the future state as we advance on delivery system reform. Mark referenced earlier Secretary Burwell's announcement around targets to achieve delivery system reform. So I would say we're well into the transition into our future state, which is much more people-centered, outcomes-driven, relies or expects and incentivizes coordination of care, and uses new payment models that we've been talking about today, which include, of course, ACOs, but also other types of value-based purchasing, bundled payments, episode-based payments, and really relies on transparency of data, not just to the general public, but very importantly, back to the providers so they can understand their performance and utilization, learn from that, and act on that. And this is important, obviously, not just for CMS and for the public sector, but this must occur also within the private sector for true transformation to occur. Next slide. So in an article that was published last year in JAMA by Marilyn Taverner, Rahul Rajkumar from the Innovation Center, and Patrick Conway, all from CMS, they identified really 4 basic categories of payment. And this is directly relevant to the targets that were set by the Secretary. So category 1 is fee-for-service with no link to quality, which is, of course, where we've been up until recently. Currently, that is a very limited category within Medicare or CMS payments in general. I think we're at somewhere around 10 to 15% or less of payments are within this category. Category 2, which is where the bulk of payments are now, are in the fee-for-service realm, but with a direct link to quality. So examples here are hospital value-based purchasing and the readmission reduction program, the physician value-based payment modifier. Category 3 relies on alternative payment models like ACOs, so like the Medicare Shared Savings Program and the Bundled Payments Initiatives. These are built upon the fee-for-service architecture, but it's a category in which providers share in savings and have either one or two-sided risk associated with the model. And then category 4 is population-based payments, where payment is not directly triggered by a service, so volume is not linked to payment. But clinicians or organizations are paid for the care of a beneficiary over a period of time, for example, for a year. So some pioneer ACOs will be in this category. Some Medicare Advantage plan payments are in this category. And so getting back quickly to the Secretary's announcement, the goals there are that by 2016, that 85% of payments are fee-for-service linked to quality, which I would say covers categories 2 through 4, and that 30% are alternative payment models, so categories 3 and 4. And then by 2018, that 90% of all payments are fee-for-service linked to quality, again, categories 2 through 4, and that 50%, so fully half of all payments, are through alternative payment models. So next slide. So this just sort of shows the trajectory that we have articulated for value-based purchasing, and here value-based purchasing is sort of all-encompassing, doesn't mean a particular payment model. So really initially it started off just with ESRD or dialysis facilities, which is a bundled payment program, and hospital value-based purchasing. Used measures that had really been around for a long time that were very familiar to providers, but probably weren't the kind of measures that we really need to drive improvement. Where we are now in the middle column, that's been expanded to include physicians and actually also to include more recently skilled nursing facilities. And there's been an increasing emphasis on patient experience, cost, and outcome measures. So the portfolio of measures has really started to shift to where we've really removed a number of process measures and added in more outcome and patient experience measures. And then ultimately, longer term, we're really focused on aligning not just the measures, but I would say also the policies and incentive structures across multiple settings of care and at various levels of aggregation, continuing to really rebalance that portfolio of measures to be much more outcome appropriate use, cost, patient experience heavy, and that we're really addressing all 6 national priorities, which I'll get to in a minute, and that there's ongoing support for quality improvement and engagement of clinicians as well as patients and community organizations. Next slide. So just to recap the 5 recommendations that came out of the report for improving accountable care measurement that Tom just articulated. So I won't go through these, but this is really just a reminder to keep in mind as I talk through the next few slides. Next slide. Okay, so I think it'd be helpful, I think, to sort of frame how we're thinking about quality measurement and our strategy for quality measurement and overall for quality improvement within CMS. So next slide. So our quality improvement strategy, the CMS quality strategy, is built upon the foundation of the 3 aims that you see here: better care, healthy people, healthy communities, and affordable care, really lowering costs through improvement. Next slide. We rely heavily upon the National Quality Strategy as the foundation for the CMS strategy. So the 6 National Quality Strategy priorities are also the 6 goals of the CMS Quality Strategy. So patient safety, patient and family engagement, communication and care coordination, effective prevention and treatment of disease, working with communities to promote healthy living, and finally making care more affordable. Next slide. And we identified a number of really important foundational principles that really have to be layered across all of our work. So reduction of disparities, strengthening infrastructure and data systems. And here we're not just talking about CMS data systems, but really also data systems and data infrastructure and electronic health record or health IT infrastructure within organizations, provider organizations, enabling local innovations. And this is something that we think that the use of outcome measures really helps to promote, to allow providers and facilities and health systems to innovate on how to get to those outcomes. And then one thing that you'll see throughout all of our work, particularly with the quality improvement work and the Innovation Center work, is the use of learning and action networks or learning organizations so that providers, and I use that term broadly, can learn from one another as to what works to improve health outcomes. Next slide. So this slide just shows you all the different programs, and I clearly need to update this slide because there's been a couple that have come on board since we first started using this slide, and that includes the skilled nursing facility value-based purchasing program, as well as the skilled nursing facility quality reporting program, and then some of the work that's happening through the Impact Act to align quality measures and actually the elements within those measures across post-acute care settings. Next slide. So historically, the landscape of quality measurement, this is just sort of repackages, I think, what Mark mentioned earlier, has been a very, very siloed approach to quality measurement. So even within the same setting, if a given setting, like the hospital programs or the physician programs, had multiple programs, there may be different measures within each one and different reporting criteria. It's obviously very burdensome to providers for that, to have that. There really wasn't a very clear measure development strategy and not really clear articulation of where the measure gaps were. Very reliant on process measures, so there really was a significant diffusion of focus on where to improve. So really too much noise, not enough signal. Not only is this burdensome to stakeholders and providers, but it is to CMS because historically CMS had developed stovepipe solutions or IT solutions to quality measurement across these different programs. Next slide. So the National Quality Strategy really provided the framework for us for how we think about quality measurement. And it really didn't just happen for us. I think it happened with the National Quality Forum and also with private payers. So we really think about measures in the context of the 6 priorities of the National Quality Strategy. And you see them here on the slide with some examples beneath each one. And for each of these, we think that measures should really be focused on being outcome-oriented whenever possible, and certainly being patient-centered, and that kind of what Tom described, and that's in the report, that measure concepts within each of the 6 domains that are common across providers can ultimately form a core set of measures and roll up from the more granular level to, I think, the higher level. Next slide. So overall, our vision for quality measurement, of course, is to align with the National Quality Strategy to really focus on developing measures that are most meaningful to patients and families as well as to providers, again, focused on outcomes, patient experience, appropriate use, et cetera. To really prioritize cross-cutting measures, so that's something that Tom talked about, that are applicable to broader populations but may be disease agnostic. Function is an area we've been spending a lot of time working on at CMS, symptom management and quality of life as well. Wherever possible, align measures across CMS programs, and also where possible with states, private payers, certification bodies, et cetera. There's a lot of work going on there right now, particularly between the public and private sector that's recently begun. And then removal of measures that are really no longer appropriate. So we've seen over time that a number of measures, particularly processed measures, have become topped out, where at one time there was significant variation in performance and there was definitely a gap in performance. There no longer is. And so those measures, we want to reduce burden on providers to not have to report on measures where everybody is performing very highly, and now they can really start focusing on other areas where there still is significant performance variation. Next slide. So that, as I mentioned, we're really focusing on outcome measures. Thank you. So, of course, outcomes are the end results of care, not the specific technical approaches to achieve those results. So examples, of course, are mortality rates, readmission rates, hospital-acquired infections, and so forth. And we really do believe that focusing on outcomes then really allows for local innovation to achieve high performance and outcomes. Next slide. Outcome measures, though, are challenging for a variety of reasons, not the least of which is finding good data sources for outcome measures, which is one of the reasons that we have historically relied on claims for that purpose. We also know that outcomes are multiple factors. Sometimes providers feel like they don't have full control over an outcome, and we understand that that is. I think that I'm trying to determine threshold is for good performance, because it helps you anticipate that 30-day mortality after a heart attack. What we do know is that it's still overall too high, and that there is very, very wide in performance on mortality, and so there really is room for improvement. And we also high process measures does not necessarily translate to high performance related outcomes alone are probably the drive way that outcome and other types of measures will. Next slide. With all of this in mind, and with our delivery system reform, oops, there you go. I think back one. With delivery system in mind, we have developed, thank you, a number of key measure development that really is driving our work. Now, one, sort of what I mentioned before, to address a performance gap where there's true variation in performance, not just a measure gap. And historically, we've had a lot of measures that have filled gaps in measurement, but where there may not have been significant problems with performance. The other thing that has really changed in our measure development work is the ability to involve patients and families in the measure development process very meaningfully. And we think that patient and caregiver input is equally important to provider input in the development of measures, and both really have to be at the table together. Next slide. We also need to be reorienting measures around to be around patient-centered outcomes that span across settings. Currently, most measures are setting-specific snapshots, but as we move towards population-based payments, we need to be thinking about how we can measure across multiple settings. And I think very importantly, monitoring disparities and unintended consequences. This is a challenge. It's definitely a challenge that we face, but we, I think, are making progress on how we can do that better. And I think that this monitoring is absolutely critical so that we don't swing too far from overuse to underuse or to harm for patients because of use of measures. Next slide. There are a number of challenges, though, in developing these types of measures, and these are really more advanced types of measures. I think first defining the right outcome and performance gap, I think we're getting a lot better at that through the work that we and others have done with the National Quality Forum, through the Measure Applications Partnership, and other places as well. Engaging patients in the measure development process. I think we are certainly starting to do that. I think what we are learning along the way is how to do that well. We need to advance the science for very important types of measures, in particular patient-reported outcome measures, appropriate use measures that are much more challenging, so that more work needs to be done on the fundamental science behind those measures. Testing of measures is a challenge. Again, developing measures that reflect and assess shared accountability across settings and across providers. And then, of course, the length of time it takes to develop measures. It typically takes between 3 to 5 years at this point to develop measures. Part of that has to do with some of the challenges above around testing and so forth, but that really is just too long. We have to get much more nimble at this. Next slide. So how do we make decisions about which measures to develop? We look to a number of sources. So we, in particular for ACOs, we looked at the MedPAC recommendations, and they recommended that we move towards population-based outcome measures, the CAPS family of measures, which of course we're already using. They really felt we needed to use more appropriate use measures, and they recommended continuing with administrative claims because that really is the best source right now for population-based outcome measures until we have full EHR interoperability. I think that's the way we're going to be mainly measuring those types of global outcomes, and of course electronic data sources as well. We look to the work that the Measure Applications Partnership does, because not only do they make recommendations to us for which measures to use, they also make a lot of recommendations for where the gaps are that we need to fill. We use expert panels in all of our measure development work, where we work with national clinical and methodologic experts, and of course increasingly patients and caregivers. And we of course analyze our own data to see where we think there are gaps in care. And then we've identified a number of key areas to the CMS quality strategy, including behavioral health and better measures for patients with multiple chronic conditions. Next slide. So just a couple of examples of how the measure portfolio has evolved over time. So in the hospital programs, we've removed a number of topped-out process measures. So really have, over time, reduced the burden of that chart abstraction that happens with those types of measures. And in the value-based purchasing program, we have more heavily weighted the outcome and patient experience and safety measures. In the physician programs last year, we removed about 50 measures from the PQRS program. These were nearly all process measures that were either very, very low bar measures, checkbox measures you might say, or they were topped out. We did add in 23 more measures. Most of these were much more heavily balanced towards outcome and safety. And then we started requiring clinicians who actually have face-to-face encounters with patients to report on at least one of a portfolio of 19 cross-cutting measures. We also signaled in our rule last year that we are considering increasing that to 2 or 3 measures. Next slide. The current state for the ACO measures, I don't need to go over this in detail because Mark did earlier, but it's in 2014, it was 33 measures, and they've been in the program for a couple of years. They do align with other incentive programs like PQRS and the Electronic Health Record Incentive Program. Next slide. So again, 7 CAPS measures, 4 administrative claims measures, 22 web interface measures. Web interface is just the data collection method, and these do tend to be measures that are mostly abstracted from charts or EHRs that are then input into a web-based tool. Next slide. Last year, though, in our final rule, we ended up removing 7 process measures. So these are web interface measures because guidelines had changed. They were redundant with other measures. We did add in 4 claims-based population outcome measures. So number 1 was the SNF readmission measure. And again, remember I said that there's 2 new programs related to skilled nursing facilities. There's a SNF quality reporting program as well as a SNF value-based purchasing program, both of which do require use of a readmission measure, so that's now aligned across multiple programs. We also developed 3 new all-cause unplanned admissions for patients with diabetes, for patients with heart failure, and for patients with multiple chronic conditions. And this is our first measure that uses patients with multiple chronic conditions as the cohort for the measure. And then we did add our first patient-reported outcome measure. This is a tried-and-true measure that's been around for a little while. It's depression remission at 12 months and relies on use of the PHQ-9 instrument. Next slide. So going back to the 5 recommendations and sort of how we are looking at this in progress, I think we've made some progress towards these recommendations without even meaning to, but we still definitely have a lot of room for improvement. So identifying and prioritizing measure gaps, I think we have a number of approaches to do that. Traditional approaches, by that I mean the map work, the input that we get from our expert panels and from MedPAC. I think we probably can, though, do some more work to analyze our own data to understand where there really are significant performance gaps. Use of alternative measurement approaches, such as the layering approach, I think is very, very appealing to us and something that we definitely want to take a closer look at for future years. We are trying to move towards more global outcome measures for accountability. Again, number 3, using the most meaningful measure types. Here I think we actually have made a fair amount of progress, and I think you'll see more progress over the coming years, really trying to balance cross-cutting measures like patient experience, like screening and function and so forth, with the disease-specific measures, and just trying to be really sensitive to the burden of measures there, and using more of the patient-reported outcome measures where possible. Addressing barriers to measurement, we've sought comment on ACOs using EHR data to submit measures to us for the future. There are challenges to doing that within the context of the ACO program, but we know that some would like to move in that direction. So we are thinking about how we can build that into the program in future years. And then assessing opportunities to continuously improve. We do get a lot of feedback on how the measures are working, what the burden is to using these measures, and then of course looking at our own data analytics. We also do give data to the ACOs on a monthly basis at their request. We also do aggregate data reports back to the ACOs on a quarterly basis so that they can look at ways to continue to improve care within their organizations. Next slide. So overall, future vision for not just the ACO program, but across the board is that we advance on technology and innovation to focus on eliminating patient harm, that we can spread best practices much more rapidly through our learning and action networks and other mechanisms, that we reward eliminating harm and improved outcomes. We're obviously on that pathway. That train is out of the station. Better use of EHRs, monitoring, and data analytics in order to drive improvement at the point of care. Learning from other industries, such as lean work, reliability science that can be applied to healthcare, and then that systems redesign through delivery system reform achieves the 3 aims of better health, better care, and lower costs, or as we like to say now, smarter spending through quality improvement. Next slide. I think that may be my last one. Okay, and that's it.
Great. Thanks to all 3 of you for those illuminating presentations. Thank you to our speakers for joining us today. Thank you to all of the attendees who joined us and stuck with us to the end. I hope that you found it interesting and helpful, and we appreciate your attention. Have a great day. This concludes our webinar.